Welcome. You're watching Eye on Harvard, brought to you by In Time TV. I'm Ogan Gurel. We have a great program ahead of us. And our guest today is a nationally recognized radiologist, has an extensive Harvard connection, is based here in Chicago area, an ultrasound radiologist, Dr. Jason Birnholz. Quick introduction. He got his bachelor's in Union College, his MD at Johns Hopkins, and he has an extensive connection to Harvard, post-medical training. He was the residency at Mass General Hospital, was associate professor of radiology at Harvard Medical School, Mass General Hospital, also was working at the Brigham for some time as well. And through all this capacity, also consulted at the Children's Hospital Medical Center, all the major Harvard institutions, and has since been here in the Chicago area leading an ultrasound radiology group. Dr. Jason Birnholz, welcome.
Hi, thanks.
And your firm is, or I should say...
It was easy to consult at all the Harvard hospitals because there weren't very many ultrasound people in those days. There was me, so I got spread around a lot. Yeah,
I noticed, I mean, you basically had your fingers in all the Harvard hospitals. We'll talk a little bit about that history. The title of today's show is Fetal Medicine, How the Field Began at Harvard. And we have one of the pioneers, Dr. Birnholz, with us to discuss that. And perhaps, very importantly, where it is going. So welcome again. So you were mentioning about you had your... diagnostic capabilities or consultative services through all the Harvard hospitals. Tell us a little bit about the environment back then.
Well, I was back and forth to Harvard a few times with some time off at MIT doing a little research stuff. It's very Boston,
right?
Either side of the Charles from time to time. But in those days, and we're going back now to the 1970s, and this was just before or at the time that CT scanning was first coming in.
Mm-hmm.
So that imaging was primarily X-rays in its various forms, whether it plain films, fluoroscopy, or interventional radiology, which didn't even have that name then, where you injected contrast material into various vessels and lit them up, looked to see where they were, how many, how few, and things like that. So it was a field in which there were not many options for imaging. And then ultrasound came along, and it was really not very good, but it showed some things that were very unique.
Mm-hmm.
And so I happened to be in there more or less at the beginning,
right.
And it's because it was something new, which seemed to have a lot of potential at the time, and there was very little competition. So that's kind of the stage.
So ultrasound, I mean, our audience is a general audience. Obviously, there are some medically trained people in our audience. But to some extent, at that time, ultrasound was a totally different modality. Well, it still is, obviously.
Okay, I guess.
But you were mentioning,
the basics. The idea was you are using sound waves to make pictures. They're very high-frequency sound waves, so you can aim them a lot like a laser.
Mm-hmm.
But there's no radiation involved. And basically, it kind of derives from what's done with sonar,
mm-hmm.
in which you just send off a pulse, you ping it somewhere, and you listen for the returns. And if you know how long it takes for something to go back and forth, you can tell where the reflector that's sending your ping back to you happens to be. And you do this with lots and lots of individual pings very, very quickly, and you sort all of those out, the computer sorts them out beautifully, into a map of where those little reflectors are in space. So basically you build up a very fine image of things using sound only, but high frequency sound so that you can aim it like light, except instead of bouncing back from the surface, it goes through and through.
Right. And so it was a completely different modality than conventional radiology, if you will, which were using X-rays.
Yes.
And
exactly.
Harvard has an interesting tension between being innovative but also very traditional.
Yes, very conservative.
Very conservative. Well, what was it like bringing something totally left field into the system?
It was not easy at all, but it's only because there were so few alternatives in imaging that it facilitated things a lot.
Right.
When I spent a little time at Stanford which is exactly the opposite, very experimental, less conservative. The end results seem to be about the same, but it's because I had a chance to develop this at Stanford first before bringing it back and introducing it, in fact, at Harvard, that I had the experience of an environment that was a little bit different. But in terms of patient care, very conservative care is really the best. You really have to balance those.
Right.
And even though Harvard is very, very conservative, they are still at the leading edge of things that have gone on forever.
Well, that's an interesting dichotomy and balance, which I want to explore, because you were in that, in reality, as it were. Let's say you were bringing in new technology and clinical technology in the Harvard system. What advice would you have for someone bringing that to help balance this conservatism and innovation?
Oh, well, the thing is, you have to be very, very well grounded in what is traditional and done. And you do everything in the context of what's traditional, as opposed to here's something brand new, let's throw out the old.
Right.
It is, how does this enhance what you've been doing very well for a long time? So that the way to introduce something is by being very, very good at what was there before. Otherwise, it's really impossible. And then there's no conflict because you're adding to what you know as opposed to trying to replace it.
Right.
And in fact, you accrete knowledge.
Much like the Mass General itself physically, in terms of all the buildings agglomerated together.
I guess.
So the first application, and I'm simplifying of course, was in fetal medicine.
No, actually that's not true at all. But that's the one that's become the most popular on a worldwide basis now.
Okay. So tell us a little bit about how it was first introduced.
Actually, going back, I guess, to the very beginnings, were shortly after World War II. And there was a notion that you could use sound waves to find gallstones. But interestingly enough, the very first series of papers were by two guys, Wild and Reed. Wild is a physician, Reed is an electrical engineer. And they were using sound to try to identify breast tumors. This is 1952. So the original had to do with other parts of the body entirely, not fetuses at all. And in the 1950s, there were some preliminary things on trying to look inside livers, for example, to find liver tumors, to find abscesses. And it wasn't until late 1950s that the notion was, well, why don't we try this for looking at fetuses?
Right.
And remember, the images in those days were below crude. They showed very, very little. I should really say something about...
Well, let's talk about that right after the break. We have a short break coming up.
Very good.
And we'll talk about that development in the 50s. Stay right there. You're watching Eye on Harvard. Our guest, Dr. Jason Birnholz, nationally recognized radiologist. Stay right there.
Hi, I'm Michael Momando. You're watching the In Time TV network, where professionals save big time connecting with their community worldwide. If you're in the restaurant or hospitality industry, I invite you to tune in to Restaurant Talk, where you can email or call in questions, comments, or concerns. You may even be a guest on our weekly Saturday show. To see a recent tasty episode of Restaurant Talk, please tune in to www.intimetv.com.
When someone abducts a child, they're not about to advertise it. But we will. Sign up at wirelessamberAlerts.org to get free Amber Alert text messages on your cell phone. Help put a child abductor out of business for good. Wireless Amber Alerts. A child is calling for help.
Welcome back. I'm Ogan Gurel. You're watching Eye on Harvard. Our guest, Dr. Jason Birnholz, who goes back in the Harvard system, the Harvard Medical School, Mass General Hospital, Brigham Women's Hospital, Children's Hospital, etc., as one of the founders, pioneers in ultrasound radiology.
Oh, thank you. That's very kind.
So we're talking about the 1950s.
We are, but I need to say something about ultrasound.
Okay.
To set something about why it's different and how it's different. And that's the concept of mapping. When you make a picture of something, it doesn't matter how you do it, you're making a map of whatever it is you're looking at. And it'll show some things, but not everything. Mm-hmm. Now, when you make a picture using X-rays, you see some things that have to do with the atomic structure of what you're looking at. For example, you can see bones really well because their calcium has an atomic number of about 12, which is much higher than hydrogen, which makes up water of soft tissues around the body. So bones show beautifully. But within soft tissues, for example, they all look the same because they're all basically the same atomically.
Right.
Now, the thing about ultrasound is that it shows you features that have to do with how molecules are put together, but not atoms. And the maps are very indicative of the physical properties of tissues, like elasticity. So that you see things with ultrasound that have to do with soft tissue properties that X-rays cannot show. Now, in the early...
In a sense, the resolution, or I shouldn't say resolution, but the interaction with the matter is not at final level, namely at the atomic nucleus.
It maps something else.
At a broader level, but you almost get more information, functional information from that.
You get much more information about soft tissues, but for example, there are areas where you get no information. It's terrible for bones. You can't see through air or gas. So the chest X-ray, which does great because of all the air or gas, that's an area that you can't look at with ultrasound. So for soft tissues, you see a whole range of things you cannot see with X-rays, even with CT scans, because the mapping is different.
To some extent, as you indicated, functional properties.
We'll come to that.
Okay.
The answer is yes. But just in terms of the mapping, it's very, very different.
Right.
Now, because it involves no radiation, ionizing radiation exposure at all, in the early days people said, oh, well, why don't we try this because it doesn't involve X-rays, but X-rays must be much more valuable, much more informative because they're not as safe. So ultrasound was done for its safety, not for the information that it provided. And because people simply did not want to X-ray fetuses, and you couldn't tell very much by X-raying them anyway, for a lot of reasons, the thought was, well, let's try ultrasound.
They don't have a lot of developed bones, for example.
Very early on, that's true. Late on, not so true. But nevertheless, it was done for safety, not because, oh, let's do this because it'll tell us something really special. And this began more or less for fetal uses in Scotland in the late 1950s. And then actually almost simultaneously here in this country. But it was very limited. It was, for example, can we tell the size of the head, for example, so you can decide how far along a fetus might be. And it wasn't until much later when the images became clearer and better detailed that people started to do more with it, such as trying to identify major anomalies or abnormalities. And then this is expanded into much more functional kinds of assessment, like is a fetus healthy or not, deliver or leave inside? Is there a risk of going into labor early? And those are really functional questions as opposed to just how our fetus is put together.
So tell us a little bit, you're mentioning in the 1950s. What is the Harvard connection? How did that start to...
Oh, well, no, it wasn't until later, into the 70s, when, as a matter of fact, after I came back to Boston from Stanford, and I hope you don't mind my making this a personal history, but that's the one that I recollect the best.
That's what the program is about.
Oh, well, in that case, rah-rah, Harvard. Very, very fine. I was there. I'm glad. Okay. Anyhow, in the 1970s, there was the Boston Hospital for Women, which existed as a complete separate entity and took care of all of the obstetrical things in the Harvard system. And then there were the other hospitals. And my appointment when I came back from my sojourn in California was at the Peter Bent Brigham Hospital as the head of ultrasound. And since I was the only ultrasound person around, and people thought, this has applications in obstetrics, why don't we, from the institution, make you radiologist in chief at the lying-in hospital? I love that title. It's the best title I've ever had. I was very happy with that. Yeah. And actually, I spent all of my time at the lying-in hospital avoiding the Brigham and doing my ultrasound things. And what I sort of realized at the time was, and in fact I had very little experience in obstetrics because my other hospitals, like the Mass General, had no obstetrics. And so my exposure was minimal to that point. But it occurred to me that there was no field in all of medicine where there were such important decisions to be made on so little information. I was hooked up very early with a really remarkable obstetrician named Fred Frigoletto, who probably the founder of what's called perinatology, or at least one of its founders back in those days, which was somebody who was a good obstetrician who then migrated into mainly taking care of so-called high-risk problems, women with diabetes, with high blood pressure, with medical issues. And I was astounded. Fred had very good judgment, but how can you decide how to manage somebody when you have so little information about fetuses? You can get lots of information about moms, but what you really want to know is what's going on with them. So with Fred, I started to develop a whole series of protocols for how to look at fetuses and how to extract some information about them. And that's really where the genesis of this all began.
We'll talk about that right after the break. Really, it sounds like it transformed the field.
Absolutely did.
Stay right there. We were watching Eye on Harvard. Our guest, Dr. Jason Birnholz, talking about the beginnings of fetal medicine.
No matter where you live, life in the oceans depends on you. To keep our oceans clean, recycle and dispose of trash properly. To learn what you can do, go to keepoceansclean.org.
Once they've outgrown their toddler seat, they're still not ready for adult safety belts alone. 4'9" is the magic number. Until then, kids need a booster seat. Make sure your little pumpkin gets there safely. Visit boosterseat.gov.
Welcome back. You're watching Eye on Harvard, brought to you by In Time TV. Our guest, Dr. Jason Birnholz. Glad you could be here. Fascinating topic. How well, I shouldn't say the start of fetal medicine has obviously a long history, but really new
No, it doesn't have that much of a history. You know, it's very new on the medical scene.
I meant obstetrics having a long history, but to the extent you brought up a very interesting point where obstetricians up until ultrasound were making life-changing decisions, crucial decisions on the basis of minimal information. So that was changed.
Yes, minimal information about fetuses. Now, you can get away with an awful lot in obstetrics because nature does such a great design. And things will often turn out best with least attention, but it's in the high-risk cases where you really have to do some maneuvering to avoid all the metabolic problems that can go on with diabetes, for example, or high blood pressure, small vessel disease. And so it made a very big difference in medical management, but there are some things that are unique about obstetrics also, which is wellness testing. Because even though things are normal most of the time, there is astonishing anxiety in pregnant women. Hormones go up, the crazies come out. That's probably not a sensitive term, but it's very descriptive. Nature makes women supremely protective, and they will worry about everything. So it's a field in which wellness testing is very, very important.
Right.
And that's another of the threads of why ultrasound has just blossomed into such a major worldwide technique.
Because, as you mentioned at the outset, it's not ionizing radiation. You could do the wellness testing, as you say, which it has a medical need, but even more importantly, a psychological need, as you put it, or I'm interpreting.
Yes.
But to the extent that it's not ionizing radiation, it's very safe.
It is. And you can do it over and over again. And that's the other thing, is that you're dealing with organisms, fetuses, that are developing and changing over time. So you can look as often as you need to monitor that process.
And this is not a medical program per se, but as a radiologist who's involved in or working with physicians in the care of patients and mothers, what is the typical frequency that's recommended or what's the protocol, I should say? There is no typical.
There is no typical protocol, and this continues to evolve. Now, for many years, most of the European countries have actually mandated a series of ultrasound exams by law. So that part of obstetrical care includes ultrasound. But here it's always been a matter of what does the patient's physician think is appropriate for each individual patient. And this continues to change every few years, and it changes as the equipment gets better, as the imaging capabilities get better. In addition to having images that just show an awful lot more than ever before, the equipment is also much easier to use. There are a lot more automated subsystems, and that has really expanded the use of ultrasound because it's now done very often, at least at some level, in private practice offices all around. The equipment has become affordable and automated so that you can have certain screening things done with minimal technical education.
So basically by a primary care doctor or emergency room physician, not necessarily with the involvement of radiologists.
Typically not for obstetrical issues, but that's true. In fact, emergency room physicians now do an awful lot of ultrasound.
Right. I know this is a sort of a settled issue, a moot point, if you will, but safety was a concern in the early days of ultrasound. And the reason I ask that is every technology when it comes out, particularly medical technology, has safety issues. And I'd be interested to know how that debate evolved in the 1970s and how it was resolved.
Well, you can never resolve issues of safety. It's very much easier to prove that there's a harmful effect than to prove that there is safety. I mean, after all, when do you stop testing? You go on. And the issue is especially critical when you're dealing with fetuses. Or some people make the distinction and say, well, what about really early pregnancy and dealing with embryos? I mean, there can be nothing more vulnerable than an embryo.
And I'm sure there were concerns that high-frequency sound waves could be disrupting tissues, etc. So how did that debate...
First off, there are two separate threads here to keep in mind. One is just the physical thing. Can you cause harm with sound waves? And the thing is, at very high frequency sound waves pass through things without a biological effect. There are very intense low frequency sounds that will disrupt things, but the higher you get in frequency, the more this becomes like a ray that passes through without depositing energy significantly on the way by. So physically, you don't expect very much of any possible effect, and there's no memory. That is, once the wave passes through, it's gone. You do it again, it's like starting all over again, as opposed to ionizing radiation, for which there's a memory effect. Every dose accumulates.
Interesting, yeah.
So that's another major difference. But the other side of things is, what is the harm? Nobody ever asks this, but it's such a basic and important thing. What's the harm of not doing a study in terms of things that you don't find out?
And there's always an opportunity cost, if they call it.
Well,
yeah.
The thing is that if you don't do ultrasound, you miss so many things that you can intervene for and make a difference for, that completely overwhelms a minute theoretical risk.
Right.
And on the other hand, there are registries, people start here and there all around the world, and we're never able to show any substantial effects.
Right, sort of like proving a theorem or a physical law. You can't necessarily prove that something is safe. You can just have sort of diminishing returns. Let's talk about that a little bit more later, and some more about the development of fetal medicine right after the break. Our guest, Dr. Jason Birnholz. I'm Ogan Gurel. You're watching Eye on Harvard, brought to you by In Time TV. Stay right there. We'll be right back.
We're moving faster than ever before. Even your ideal prospect will see your ad, click to your website, then decide to read on or read none in a mere 1 to 7 seconds. After that, you become invisible. So what's the answer? How do you capture and hold the attention of your target audience? In Time TV. The In Time TV network broadcasts industry-specific TV shows to the people who buy your products: surgeons, primary care physicians, dentists, podiatrists, chiropractors, hospital administrators can now watch live in-time programs on widescreen, on their PC or laptop while checking email. Shows can even be viewed on a cell phone during a train commute. In Time TV is peer-to-peer TV that covers the hot topics in industries that you sell to. In-time TV shows are broadcast worldwide via the internet, yet the cost of running a 60-second commercial is a fraction of what you'd pay for a display ad in a trade magazine. In-time TV is what your target audience is watching.
Keeping professionals engaged worldwide.
Mom?
Dad?
How long should I wait for you?
If I'm at soccer practice.
What if something happens? Will you come get me?
There's no reason not to have a plan in case of an emergency.
Should we go to the neighbor's house?
And some extremely good reasons why you should.
Can you tell me?
Talk to your family about what you would do in case of an emergency.
Welcome back. You're watching Eye on Harvard, brought to you by In Time TV. I'm Ogan Gurel. Our guest, Dr. Jason Birnholz. He is a partner, a radiologist in the practice Diagnostic Ultrasound Consultants here in Oak Brook, Illinois. They have a website that has a lot of interesting pictures on it in terms of ultrasound pictures. It's www.amnionet.com. Should be on your screen there, www.amnionet.com. And we'll hopefully see a few of those pictures from that website, and when we bring those up, we'll talk about them. But let's go back to fetal medicine, the 1970s, late 1970s at Harvard.
We should move up to the present, but okay. Yes, what would you...
And so how did that progress from there?
Oh. in fits and starts. Here's an example of something practical. This was it was 1983, and there was a report in the New England Journal, and it was about using ultrasound to tell whether a fetus was male or female.
Oh, right.
Gender, boy or girl. This was turned out to be the first report, and I remember that very well because I did that, and it's funny. It's the only paper that I ever submitted to the New England Journal that got accepted without any revisions, which really surprised me. I guess they thought this was a controversial topic, and they liked it. And there was a whole flurry of...
Could also be that there weren't that many experts, so they just...
No, it was kind of novel. It's actually a very easy thing to do. Use the college method to just look between the legs, see what's there. After 12 weeks, it's very simple and straightforward. Before 12 weeks, you can't do it because that part of the anatomy hasn't really developed fully by then. But I remember that there was such a flurry of articles, mostly contra, not pro, and it was, this is evil and bad. If people know this will change their entire habits. People will decide they don't want one model or another, that the abortion rate will skyrocket. Of course, this is ridiculous. It never, ever happened.
Well, that's interesting to talk about. Why did it not happen? I mean, well, I do remember that debate, actually. And
it was no debate. It was just a few crazy people that brought up the notion. And as a matter of fact, the same people brought up the same notion when amniocentesis began to become done more, which was about 5 or 6 years before this particular paper for ultrasound. And it keeps surfacing. But I kind of chuckle about this because now, at this point in time, this is such a common thing. You find it showing up in TV dramas and movies, and everybody does it. It's like nothing to it. But that was the very beginning of it. And at the time, how radical and strange. And it was a nice example of an anatomic feature that you could tell very, very well. And if a patient wants to know, absolutely, why not? Why keep it a secret? And if somebody doesn't want to know, well, then it should not be revealed to them. They're entitled to their choice as a patient.
Sure. So you would espouse the idea that basically people should be entitled to as much information as possible, and they should make their own decisions based on that information.
Oh, yes. I mean, patients need to be, involved in their own care. And sure, the more educated a patient is, the more they can participate in things. It's very important.
So this is veering a little bit from the medical, but we're obviously interested in general ideas.
But half of your viewers are going to be women, and the other half are going to appreciate women, mainly.
Right.
And so this may not be a medical show, but this
it's not a medical show.
This is a basic human thing.
No, it is, and that's why I think it's fascinating. So what I mean to ask is, it seems reasonable enough to assume that we should have as much information as possible. People should make their decisions, etc. What do you think drives a push towards individuals or groups that say we shouldn't have this information? Which it's a common theme. It's not just with fetal ultrasound, it's with genetic testing, it was with amniocentesis, it's with many things in life.
I don't know that there are necessarily groups that are contrary to testing or finding information out. I remember a conference that I was at a long time ago. It was at the Vatican, and it was about prenatal diagnosis of major congenital anomalies, and nobody, including the Vatican, disagreed with knowing what's going on at all. It's what you may do with that information for which there's sometimes some question, but knowledge itself is never a bad thing. And in fact, the more knowledge you have, the more you can act appropriately. Now, there are some individual patients who have an attitude that everything will be all right if I don't ask any questions. And as soon as I start asking questions, things will go wrong, and I'll find out things I don't want to find out. And that is a perfectly reasonable choice, and for those people, prenatal diagnosis is not a good option. It's just like in years past, many people would opt for home birth as opposed to a hospital delivery, and which is absolutely fine if things are totally normal. If they're not, then it's potentially disastrous. So again, people are entitled to their choices. The more they know, I think probably the better those choices will be in terms of a good outcome.
So there might be, in addition to the sort of superstition aspect, and I don't say that super pejoratively.
That is correct. No, that is
but I think it's not
thinking.
insignificant. Some patients, some mothers, some families don't want to know because they just feel that's going to...
Oh, no, this is not just about whether it's a boy or a girl.
No, I know,
Whether things are normal,
exactly, right.
or normal on it. Sure. I think that really has to be true. And the patient's choice needs to be respected.
Right. So let's fast forward a little bit. We've been talking about the 70s and 80s. And I think we may have some pictures to show our audience.
Oh, okay.
So what is some of the developments now? What's the state of the art now?
Well, if there are any pictures to show, bring one up and let's see.
Okay, here we have one.
Okay. All right.
Tell us a little bit about that.
Yes, this seems to have got a little squished inwards, but nevertheless, this is first off, it's a 3D image, and 3D images are very photograph-like. This one shows a fairly early embryo. This one might be, let's say 9 weeks along, which means 7 weeks after conception. And so this little being would be overall about 1 inch long. So top to bottom is 1 inch. You see the head up on top, hands in front of the face. That big tube coming in from the lower left is the umbilical cord. We see the legs down below. So this is an example of seeing a being very early in pregnancy. I mean, less than 2 months after conception.
And that is a normal study, not just a research study?
No, it's perfectly normal and ordinary.
I meant people in the general public can get that.
Yes.
Well, we're going to show another one. We're going to come right back right after the break.
Good.
Ian Harvard, stay right there. Dr. Jason Birnholz, our guest. Look forward to seeing you just right now.
Daddy's little girl till heaven home.
It's easy to tell if you've had way too many. But what if you've had just one too many? Buzz driving is drunk driving.
Hey guys, thanks for coming.
Are we in trouble?
No, you're not in trouble. I just want to set some ground rules.
Like what?
Well, remember last week when you hit Vinny in the head with the shovel?
I do not recall that.
Of course not. Well, it was pretty graphic. Too graphic for the kids. So I'm going to have to block you.
I got to make this up to you. This is Vinny's watch, and I want you to have it. You deserve it.
Thank you. That's really not necessary.
No. Come here.
Welcome back. You're watching Ion Harvard. Our guest, Dr. Jason Birnholz, a pioneer and current practitioner in diagnostic ultrasound, particularly in fetal medicine. Earlier in the show, we were talking about the development of the field, how Harvard played a role in that development, balancing the conservatism of Mass General, Harvard Medical School with the innovation. I think that's a fascinating topic which we explored. Right now, we're looking at some images that are done, as you mentioned, on a routine basis. These are not research images. These are what your patients or your referrals get, on a routine, typical basis. So we'll go through some of those images. You can find more at his practice's website, www.amnionet.com. Let's pull that website name up there.
Okay.
And here's one image.
Okay. These are also very early embryos, earlier than the last one we looked at. But you see that there are two of them. Mm-hmm. They're in separate sacs, twins. And in fact, one of the very earliest uses of ultrasound, going way, way back into the 70s, was, are there 1, 2, 3, or 4 in there, or whatever number? And easy enough thing to do, but very, very important for the management of the pregnancy.
As mentioned, you can find these images and more information, interesting information, at www.amnionet.com. So, with fertility treatments, there's higher frequency, higher probability of multi-parent pregnancies?
Not as much as there used to be. Now the fertility enhancing drugs are titrated much more carefully, but there's still some women who get an all or nothing response. They'll get nothing, 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 and then bam.
Well, in that context, in this wellness approach, and I would imagine ultrasound figures a pretty important role, especially for...
Well, it's interesting. Things often start with special cases like twins or triplets and their needs, or a woman who is diabetic or who has congenital heart disease, and then it migrates out to everybody. And the notion from the 70s of identifying high-risk patients, which is still done to some degree, is a little bit unfair, because basically every pregnancy should be treated as a high-risk patient or a high-risk pregnancy, and everything done. Now, most things will not need to be done, but I think if everybody is treated with a high level of worry, it makes for better overall care.
Let's see another image. Let's see if we can pull up another image from... there we have.
All right, a little chubby face. I don't know exactly how far along this one is, but probably about 23 or 24 weeks. There's beginning to be a little deposition of fat in the cheeks, and the face is a little bit more expressive. It's kind of interesting that when you look at fetuses, and they're, let's say, below 20 weeks or so, there are no facial expressions. They're pretty much the same all the time. And in fact, one of the really great uses of this whole new technology, the 3D imaging, for example, is the basic question in all of obstetrics, which is a fetus healthy, be left alone, or somebody who is sick, compromised, needs to get delivered immediately?
Right.
Or is beginning to go downhill and maybe needs to get delivered in a day or two?
And ultrasound is real time.
Yes, but the thing is, the reason I've brought this up and why it's so pertinent to these images is that how do you tell if an infant is sick or in trouble? I mean, this is something moms do all the time.
Other than...
Well, they could be crying,
right?
But we're not going to hear that. So
we're talking about illness or sickness,
them.
Not from an anatomic perspective, but from how they feel. Is that what you're referring to?
Yes, you're using the fetus to tell you about its environment. And so you look at a face, any face, you do this automatically in infants, and you say, that is a happy infant, or at least somebody, or sleeping infant, but not sick.
Right.
And so when you look at some of these face views, like we've had up here, that's very early. But
tell us a little bit about this picture.
Well, before we get to that, the thread that I was on is you're trying to use the images to let the fetus tell you, am I serene and happy, or am I really in trouble? And it's just looking at faces, and you do this automatically in infants and children, and so the idea is do the same thing with ultrasound, and you can tell an awful lot about whether they are basically happy or not, or at least distressed, which is what you really want to discover.
So modern day radiologists in the fetal medicine field have to almost be like mothers and fathers, interpreting the facial expressions of the fetus.
Well, when you're you're a radiologist, you're doing an imaging study, basically you're using vision to do a physical examination task.
Sure.
And so this is not going to be any different from...
Yeah, I know. Conceptually it's not different, but it's fascinating to look at it and say that infant looks distressed, because typically in radiology, yes, you're using visual images, but you look at somewhat static. The bones are broken, this cancer is there, etc., etc. This is, you're looking at...
Oh, yes, and you can watch them continuously and see how something about their behavior, and that's really what you're trying to decide.
I guess that's my point. You're looking less at structure and anatomy, which is the bulwark of radiology, but you're looking almost at behavior, radiological.
Oh, yes. Well, in fetuses you get lots of behavioral clues because their nervous system is developing, and you can tell how far along they are in that process, and if it's on time, by, in fact, the way that they're behaving, the kinds of movements they make.
So that begs another question. For late-stage fetuses, can you start to discern personalities?
I've wondered about that a little bit. There are, in a gross sense, you probably can, to the extent, for example, that some toddlers are much more motor and less verbal, and some sit there and like to look at pictures and are kind of clumsy. It all evens out later. Those that sort of sit there and are less motor often tend to be more verbal, or at least verbal earlier. And in fact, you can see the same things in fetuses in that some are more active than others.
Right.
But they all have their cycles.
And mothers have often said this, like their second child would kick a lot more, or their first child seemed more comfortable, or whatever it was. I imagine there are a lot of correlates there.
Yes.
We'll talk about this fascinating topic some more right after the break. You're watching Eye on Harvard. Our guest, Dr. Jason Birnholz, radiologist, ultrasound specialist. Stay right there. We'll be right back.
Any questions?
No.
You know.
We're not magicians, we can't read your mind.
We need your questions, each and every kind.
What are the side effects, doctor, doctor?
How many times have you done this before?
Questions are the answer.
Will this react with my other medicine?
Hey, what are all these tests even for?
You have the power to say what's on your mind.
We need your questions, each and every kind. Questions are the answer. Questions are the answer.
Welcome back. You're watching Eye on Harvard, brought to you by In Time TV. Our guest, Dr. Jason Birnholz. I'm Ogan Gurel, and we were talking about seeing into the personality of fetuses radiologically. You know, there's the whole Freudian theory and all that about your mother influencing you, etc.
Well, mothers sure have to influence.
Well, they have an influence, yeah. But what I meant to say was broaden that to some extent. Do you think that this speaks to fetal environments influencing personality in the long run?
I don't know enough about personality to answer that. But, you know, the environment of a developing anything, especially a fetus, is going to have some impact on it. And as I think about ultrasound, we get away from personality for just a second. There is one of the things that I think ultimately is going to be the real major role of ultrasound. And it's in identifying what are the environmental things that lead to problems. For example, there are each organ system has a vulnerable period in its development when outside influences will cause lots and lots of problems. For example, the brain has a few distinct vulnerable periods. Between 16 and 20 weeks, for example, is a time when the cortex is really, the cells of the cortex are proliferating like crazy, and very minor influences from the outside can affect things then. or maybe not minor. Alcohol has a very big effect then. Radiation has its effect then, but not earlier or later. So that one of the when we know when problems arise in development, then you can start to say, well, what was going on at that point in time that was different from a little earlier or a little later. So I think as we do more and more ultrasound and identify, it's going to take big populations, when does a problem appear for the first time, what is its time genesis, then you can start to say, well, gee, this person was exposed to this, ate that, did this, and it had an effect.
Right.
I think ultimately that will be a great thing for wellness, identifying what are the causative problems that you can eradicate and change.
Are there research studies around these questions?
There are starting to be, but there's nothing yet in this area because we don't have enough information about the time course of things.
Because to some extent these are very open-ended questions. You just want to be following fetuses, and there's not a lot of you just want to be open to seeing what these influences are and where the problems are.
Yeah, it's to try to develop what would be a preventive medicine for fetal health. And there's just not enough information yet, but as we do more and more ultrasound, and as we do more ultrasounds per pregnancy, then this information will eventually become known. And as we database more and more things, it'll be extractable and findable.
Sure. We had a previous guest, Dr. Joseph Messer, on the show, and he had talked a lot about the initiatives he's doing in quality and the importance of gathering this information. So a lot of interesting overlaps. But we just popped up a picture there, another one. Let's take a look as we close the show. Tell us a little bit about this, Jason.
Okay. Oh, this is just another portrait picture of some little being that we've used sort of a digital scalpel to peel back the walls of the uterus, the placenta, so we can look past that. And you see somebody that's just very peaceful and serene. And this is a very typical appearance. And as a matter of fact, when...
how many weeks is this, would you say?
Oh, this is probably in the, again, early 20s. The chin's still a little bit pointed. There's not a whole lot of fat deposition. But there's some early 20s, I would say.
Okay.
Looking at it.
Let's see another one.
Okay, and this is about a 15-weeker. This is very early, 14 or 15 weeks. Just seen,
and you said before 20 weeks.
They don't
really have an expression.
They don't have expressions. They're just there.
Before 20 weeks.
Yeah.
Let's see another one.
There are all sorts. We're moving back in time, and here is an embryo in its intact little sac. Hard to believe almost that's a real life picture. I mean, there's a little heart ticking away, and all is happening because this is a static image. Oh yes, we're just going through a whole bunch of mainly early ones, and these are pictures from the AmnioNet website, which really talks about prenatal diagnostic things in the first half of pregnancy. So most of the images that show up will either be from embryonic or early second trimester times of pregnancy.
So that's where this three-dimensional ultrasonography is most...
It's used all throughout. And the things that I mentioned before about trying to tell healthy versus sick, those are expression and behavior related things, and that's typically late pregnancy.
Of course, late, after the 20 weeks period.
So you do it any time in pregnancy, you get different kinds of information at different stages.
What is the reaction of the mothers to some of these pictures, particularly late stage when they see some of the expressions?
Oh no, well they love it, even early. I mean, people bond to just hearing heart rates.
Yeah.
So actually being introduced to their little being. Here's something that's kind of interesting. This is from before the 3D time. When regular ultrasound images are cross-sectionals, they're just slices. So you can look in a profile, or you can look across the face, or straight in. And across is very, very bony. in those images as opposed to the 3D ones. Anyway, when you have a picture from the front, people relate this to other family members. It's a very personal thing, and this is actually true of all the 3D images. But profile pictures are somehow more ideal, and on seeing these, people often talk about what profession they think this child will be, or their qualities. So that's kind of a direct thing. It's being introduced in a way to your newest child.
Right.
And in fact, that's the other thing that ultrasound has really made a giant difference for, which is thinking about fetuses as a child not yet born. But this is a continuum. It's not a separate organism. This is a child who just is not quite as far along.
Right. Well, controversial points, interesting points. We're nearing the end of our program. Thank you very much, Jason.
Thank you. Fun to be here.
Glad you could make it, and really appreciate it. You're watching Eye on Harvard, another great program with Dr. Jason Birnholz. Stay right there. We'll see you next week. Thank you very much.